upcoming segments.
Thanks.
Okay. All right. Next speaker is Dr. Simpa Salami, who's going to talk about some of these commercial biomarkers, and then subsequently we'll talk about the important area of germline testing.
Thanks, Dr. Biomarkers, for your leadership and the opportunity to participate in this course today. These are my disclosures. They have no relevance to the talk that I'll be presenting today. And of course, I serve on the AUA Prostate Cancer Early Detection Guideline Panel as well as the NCCN. So in this part of the course, we'll review the rationale for doing biomarker testing for early detection in prostate cancer. We'll go over some of the biomarkers that are available, that are obtainable in blood, urine, and tissue. Then we'll review the guideline recommendations, and then the second part of my talk will be focused on germline genetics testing. A biomarker essentially is any molecule that is found in blood or body fluids such as urine or tissue that is a sign of a normal process or a sign of abnormal process, a sign of disease. Before ordering any biomarker test, a patient is before you in clinic, I think that there are some important principles that a provider should follow. One key one is, why are you getting the test? Is the test going to change what you do? Patients and providers often want a test that will tell them whether a disease is present or absent, positive or negative, but these biomarkers out there do not really give us a direct answer, so to speak. They give you a percentage risk or a score, and then you and your patient have to decide at what threshold you take action. So it is important that the provider and the patient decide on an action plan before this biomarker test are actually ordered as part of the evaluation for prostate cancer. And of course, it is important not to order too many tests or order tests reflexively. Think about how it will impact the patient's care before you order the test. There are a number of biomarkers that are available for use in the localized prostate cancer continuum. So today we'll focus on the early detection biomarkers. My colleagues have already discussed some of the blood-based biomarkers, PSA and PSA isoforms. So I'll focus on two in particular, and that's PHI and 4K score under this section. Prostate Health Index, or PHI, is obtainable in blood. It's an FDA-approved test for patients with a PSA of 4 to 10. That's the range. Outside this range, there's no data to support its use. The threshold that has been proposed is a PHI score of less than 25. Patients with this score are less likely to have prostate cancer. They are also less likely to have an aggressive form of prostate cancer. And PHI score actually outperforms any of the individual components that went into the composition of this test. 4K score is a combination of 4 different kallikreins, total PSA, percent PSA, intact PSA, as well as human kallikrein 2. 4K score actually combines these 4 different kallikreins into a model incorporating age, DRE findings, as well as prior biopsy in a patient being evaluated for repeat biopsy. It is not FDA approved. And in this seminal paper that was published about almost 10 years ago, the full model combining the 4 kallikreins and the clinical pathologic parameters actually outperforms any of the model throwing out each of the individual components. And this is a classic example of how the threshold that you choose for action can impact the performance of the test. For example, in the table that you see above, on top of the slide, you see that at different thresholds, the 4K score have different performance characteristics. And when you look at a threshold of more than 9% or more as a threshold for proceeding with biopsy, you'll be able to avoid 43% of prostate biopsies, missing only 2.4% of high-grade prostate cancer. So for this test, for example, you have to discuss with your patient at what threshold would you decide to pursue a prostate biopsy. We'll move on now to a urine-based test. The very first urine-based test to be introduced into practice was PCA3. PCA3 is a long non-coding RNA that is acid in urine that is obtained after an attentive prostate exam or prostate massage. PCA3 is FDA approved for use in patients after a prior negative prostate biopsy. In this seminal work by Dr. Wei and others, in a large cohort of men of nearly 1,000, they found that a PCA3 threshold of less than 20 has a negative predictive value of 88%. They also evaluated the performance of PCA3 in addition to risk calculators that have been discussed previously, for example, PCPT, and they found that adding PCA3 in addition to PCPT actually outperforms the performance of PCPT alone. The second urine-based test is MPS, my prostate score, that was developed at the University of Michigan. It incorporates PCA3, temperature, and serum PSA. In this work by Dr. Tosoyan and others, they compared the performance of MPS with PSA. They looked at the capacity of these two different tests to discriminate patients with high-grade prostate cancer, defined here as grade group 2 or higher, versus benign or grade group 1 disease. And you can see in the density plot to the left that PSA cannot discriminate perfectly, but MPS actually improved the capacity to discriminate between high-grade disease and benign or grade group 1. And at a threshold of MPS threshold of less than 10 has a high negative predictive value, avoiding 33% of biopsies and missing 3% of grade group 2 disease. I think these are important data that when looking at any test to determine whether you can use it in practice, that you have to ask yourself, any particular threshold that you choose to use for action, what is the likelihood of missing high-grade disease at that threshold? The third test is ExoDx. This is a measure of exosomes, small fragments of cells that are isolated from first catch urine. Unlike other urine-based tests, this particular test does not require a DRE. It assesses 3 different exosomes, SPDF, ERG, and PCA3, and this test is correlated with the capacity of detecting grade group 2 disease or higher at the time of prostate biopsy. In this work that was published about 8 years ago, they found that using a threshold of 15.6 or greater as a threshold for proceeding with prostate biopsy, you can avoid 20% of negative biopsies, missing only 2% of grade group 2 disease, and at this threshold, no tumors grade group 3 or higher was actually missed at the time of biopsy. The fourth and final urine test that we consider is SELECT-MDS. This is a combination of 2 different molecules, DLX1 and HOTC6. This test is not FDA approved. Incorporating this test in a model encompassing clinical pathologic parameters has an area under curve of 0.90 for identifying patients with high-grade prostate cancer. And there's some other emerging biomarker tests out there. One example is MPS2, which is actually an improvement over MPS that we just considered. That would include up to 50 different molecules. There's a urine prostate-seq, UP-seq, that was developed at the University of Michigan, still under investigation, a 15 transcript model. And we heard about LM3, which is a combination of clinical factors, kallikreins, and polygenic risk scores. And certainly they're also circulating microRNA that are still under investigation.
I think Vanderbilt gets some credit for MPS2 also.
Absolutely. Dr. Soyan was a fellow with us at the University of Michigan and now at Vanderbilt, who is really leading this work with Dr. Arul Shinan at the University of Michigan. And then lastly, Confirm MDX. This is the only tissue-based test available in the pre-prostate cancer setting, in the diagnostic setting. It is only useful in patients with prior negative biopsy because you actually need the negative biopsy tissue to assess these 3 different molecules. And the concept of this test is that there are molecular changes in normal prostate cells that may occur before the histologic appearance of prostate cancer itself. So if you were to biopsy a patient with a negative biopsy with ongoing suspicion for prostate cancer, assessing this, the methylation status of these 3 different genes can inform you if there was cancer somewhere in the prostate that was missed at the time of biopsy. So in this work, the work that really led to the development of this test, they found that when they repeated biopsy 30 months after the initial biopsy and then assessed Confirm MDX from the initial biopsy, it actually had a high negative predictive value of 90% of identifying patients who may have a high-risk prostate cancer. And by using this test, they determined that you can reduce the risk of repeat biopsy by 64%. So just to summarize and put things into context, in what clinical settings can we use each of these different biomarkers that we discussed? 4K score and PHI can be used in the initial and repeat biopsy setting. MPS and ExoDS, same in the initial and repeat biopsy setting. And Select MDS, there's data only in the initial biopsy setting, and PCA3 and Confirm MDX in the repeat biopsy setting.